organization here at Cardinal Health. I would first like to start by welcoming each of you to our call today and to discuss the future of drug pricing and updates with the incoming administration. And I'd also like to thank our group of expert panelists for their insights today. Today's topic is clearly on the forefront of everyone's mind, and certainly as your partner, we take that mission seriously. And today is certainly an opportunity for us to leverage our resources as an organization and provide as much clarity as we can on a rapidly evolving landscape. We really look forward to bringing the content and certainly answering any questions throughout the presentation. Since we're here at the hour, why don't we get started? At this point, let me hand this over to our head of government affairs, Rebecca McGrath.
Great, thanks so much, Dan. I'm glad to be with you all today. As you know, in late November, the current administration revived two drug pricing proposals, the Most Favored Nation interim final rule and a final rule to eliminate rebates that were high priority on the administration's agenda, but had previously stalled in regulatory limbo since last year. Since the release of these proposals, there have been a lot of questions about how they could play out, the timing with transitioning to a new administration under President-elect Biden, and what the impact might be on these rules. With today's webinar, we are hoping to answer some of these questions by outlining what we know, being transparent and honest about what we don't, and what we anticipate could happen over the next few months with the White House transition and through the first 100 days of a Biden-Harris administration. Just a few housekeeping notes. Please be sure to mute your lines throughout the webinar so we can ensure a seamless recording, so we'll be able to share it out afterwards. Also, we welcome your questions and please submit them through the chat feature throughout the duration of the webinar, and we'll try to get to as many as we possibly can during the Q&A at the end. I am pleased to be joined today by two of my colleagues and outside consultants with the Crowell and Mooring practice. We rely on them heavily to help Cardinal Health navigate through many of the legislative and regulatory issues we track and monitor, and hope they'll be a resource for you all today. First, Jim Flood is a partner and chair of the firm's government affairs group at Crowell, and he works on legal, regulatory, and legislative issues. He's a former federal prosecutor and also counsel to Senate Minority Leader Chuck Schumer. And Jim has more than 20 years of experience on issues with the White House, Congress, HHS, CMS, and DEA, and others. So thank you, Jim, for joining us. We're also joined by Stacie Heller, who's Senior Policy Director in Crowell and Mooring's Washington, D.C. office as well. And she assists clients in their efforts to shape legislative and regulatory policy. Stacie recently joined the Crowell team just a few months ago and bringing 28 years of experience with policy, patient and market access, and advocacy strategies from AmerisourceBergen and subsidiary companies. She has extensive health policy background and with a supply chain and Medicare and Medicaid payment. So with this experience, I think both Jim and Stacie will be able to walk through key issues, and then, as he said, open it up with Q&A at the end. So with that, Jim and Stacie, I'm going to turn it over to you.
Thank you, Rebecca. Good afternoon, everyone. I'm Jim Flood. A great pleasure to be here today with my colleague, Stacie Heller, to talk about the MFN drug pricing rule, to talk about the rebate rule, and to talk a little bit about the Biden administration and where all of this is going as we turn the corner in 2020 and go into 2021. What I'd like to do is I'd like to walk through a little bit of sort of the background here, sort of set the table for our discussion. And then I'd like to hand off to my colleague Stacie to talk about the details of the MFN rule. And then we'd like to talk about the current efforts to stop the rule. There's now, it looks like, at least 3 lawsuits in federal courts to stop the rule, which would become effective January 1st. And then we'd also like to talk about the state of play of the rebate rule and where that's going. And then at the end of our presentation, after we talk about the Biden administration, we'd like to take a pause and then have a conversation with Rebecca and you and answer your questions. So with that, thank you. Next slide, please. Let's start with a review of, let's set the table, as I like to say, or what's the foundation for the House? How do we all get here? So big picture, thank you. There have been numerous efforts in the last 4 years since President Trump took office to do something to address drug pricing. And it's been President Trump had an interest. Democrats on Capitol Hill had an interest. Conventional wisdom said that they would come together at some point, but that proved more difficult than conventional wisdom thought. In the United States House of Representatives, which was controlled by the Democrats for the last 4 years and will be again for the next 2 years with a smaller minority, a lot of the focus on drug pricing was around H.R. 3. And that was subsequently named sadly after his death, the Elijah Cummings Lower Drug Costs Now Act. And that was sort of a broader piece of legislation that sought to do more rather than less. In the United States Senate, as is often the case, where the margins are tighter between the parties, there was a bipartisan group of senators who had come together on the Senate Finance Committee, which is the principal committee that deals with Medicare, Medicaid reform, and tried very hard to reach a consensus, so much so that Chairman Grassley actually worked more in some ways with Democrats than he did with Republicans to try to get it done. But in the end, as is often the case, that proved difficult to do, and they were unable to cross the hurdle of getting something done in the Senate. So in the House, the legislation did in fact pass H.R. 3, the drug pricing legislation, but in the Senate, the legislation that was bipartisan did not pass, and H.R. 3, which was sent over from the House to the Senate, was not voted on in the Senate. And so starting really around last summer, President Trump started to get very frustrated with all of this. And that really led to a series of events where I think the administration felt they had promised drug pricing reform. There was an internal fight in the administration between HHS and the Office of Management and Budget on how to do that. And so I think what happened was really the president looked to his advisors and said, we've been talking about this for 4 years. How do we get something done? And he decided to do what presidents often do when they're frustrated with Congress, and that is go to executive orders. And that led to a series of 4 executive orders, and they became the predicate that pushed the HHS folks to issue rules. And that led to the issuance of both the MFN drug pricing rule and the rebate rule. Next slide, please. Okay, here, and I'm going to move through this fairly quickly, a little more detail. Again, the administration, of course, was inaugurated in January of 2017. For the first year, there wasn't quite that much movement on the drug pricing issue. And then when we moved into 2018, in May, there was what President Trump called a blueprint put out. And that blueprint mapped out a series of ways in which the administration would force broader negotiation for drugs, try to use caps, and use other mechanisms, in other words, to force reimbursement down, particularly through the Part B program for prescription drugs, and force manufacturers to try to come to the table to do something to bring costs down and lower patient out-of-pocket costs. There was also a big focus on the issue of requiring manufacturers to list drug prices in TV ads. And then the first real drug proposal was put forward, which was the International Reference Pricing Model. And that really is the predecessor to MFN. And that was this concept of, why don't we take an average or a median of all of the prices overseas, the list prices of drugs overseas, and come up with a cap? You know, what does that number look like? It's definitely lower than the cost in the United States. And let's make the reimbursement from the federal government under Medicare no higher than that. And so we, the federal government, will use our market power to try to force pricing down. As we turn the corner into 2019, that then became, in fact, a full-fledged proposed rebate. Well, strike that. The drug pricing issue continued to move on one front, and then the rebate rule was put forward, which really at its core was this concept that the administration didn't like rebates, the role of PBM in rebates, and really wanted to, as I like to say, squeeze the sponge of the drug pricing supply chain so that the money flowed down to the point of sale at the bottom, and was given, in fact, to consumers in the form of discounts or basically a rebate at the counter. Now, as is often the case, it seems more simple in policy than it was in practicality. And in addition, in 2019, there were proposed Part D benefit changes. Again, this issue of drug pricing and TV ads came up. And then there was the discussion, which started late in the year, in December, on the idea of importation. Well, if we're not making traction in bucket number one on getting a cap on Medicare reimbursement tied to an international price index, and we seem to be sort of stalling on the second bucket, which is the drug rebate bucket, why don't we move to the importation bucket and open up importation? Next slide, please. Thank you. So, okay, thank you. So as we moved into this year, into 2020, things started to heat up, and you know, as you might expect, the election heated things up. I think the president got more and more frustrated. Frankly, our team, Rebecca and others, would often hear that Secretary Azar went to the White House, and there was a heated discussion where the president, you know, didn't really understand why things weren't moving more quickly and weren't getting done. And all of that sort of pressure, or what I like to call the heat in the oven, got so hot that the president's team really had to give him options to do something that he could do personally and directly and quickly. And that led over the summer to the executive orders on the rebate rule, the most favored nations drug pricing rule. So this concept of an international price index, IPI, morphed into the most favored nations concept. Third, there was an EO, of course, on importation. And then fourth, there was, as there has been for some time, a big fight over 340B, over reimbursement and the scope of the program. It's centered around insulin and EpiPens, but in the end, that's really just a proxy for what is a bigger and broader 340B fight that I think all of you are aware of. Come September, things started to move even more. And then in November, the MNF and then eventually the rebate rule were issued. And over the course of the last literally weeks since those rules were issued, we're now in a posture where the big players here, pharma, bio, the Oncology Alliance, have all stepped in to bring lawsuits in federal district court to challenge the legality of what the administration has done. Because as we'll talk about in a minute, particularly with MFN, the administration sort of jumped over the normal law for rulemaking, which is known as the Administrative Procedures Act, and jumped to this concept of an interim final rule, which is sort of an emergency rulemaking where you have to show there's some sort of emergency essentially, and you can't follow the normal process and take all of that time, which I think many argued really was the time of the administration was running out, and they needed to do something and wanted to do something quickly related to the election. Next slide, please. And now, what about in Congress? Just briefly, let's just focus on Congress alone as opposed to the interaction between what President Trump was trying to do and Congress. As we talked about in Congress, if you look at July, you'll see a series of events, July, October, December, where really Senator Grassley worked very hard with the ranking member of the Finance Committee, Ron Wyden, a Democrat from Oregon, to try to get their version of legislation done. And for any of you who've known Senator Grassley, or might be from Iowa on the phone, once he sets his mind to something, he really digs in to try to get it done. So there was a lot of hard work done there. The senator almost single-handedly willed the legislation out of committee. But when he got to leadership, the Senate Majority Leader, Mitch McConnell, was in no mood to pass drug pricing legislation in a year. Frankly, there was an election year because, for a whole variety of political reasons. And this year, the focus has been on the Grassley bill and ACA and some other issues. And then the election came. And so now we're in this weird period, the lame duck, between the November 3rd election and the January 20th inauguration. And the Trump administration basically tried to squeeze in this rulemaking and make it enforceable and implement it and execute the go button before January 21st. And so we'd like to talk a little bit about what are the details of what they did, and what are the odds it actually takes effect versus a court stops it? And then what does the Biden administration do when they get sworn in on January 20th? Next slide, please. So with that, let me go to my colleague, Stacie Heller, to talk a little bit about the details now of the first of these rules, the most favored nation drug pricing rule. Stacie, thank you.
Yes, thanks, Jim, and good day, everyone. Thanks, Jim, for the setup. Certainly a lot of activity in the drug pricing kind of realm in the last several years, certainly, and we certainly, I think, should expect that to continue in the years to come. But I will hit some of the finer points of the most favored nations rule, the interim final rule with comment, as Jim noted. That was issued November 20th. It was issued in a couple of different ways. One, it was posted on the CMMI website, that's CMS Innovation Center website, where they run the models out of. So it was first posted there on November 20th and also put on display at the Federal Register on that same date. And these details are wonky, but they are important in terms of sort of the timeline of effective dates, comment processes, deadlines, et cetera. So we will kind of get in the weeds a little bit with you guys. The interim final rule actually took effect immediately upon its publication date in the Federal Register, which actually happened to be November 27th. That puts us at a comment deadline of January 26th. With a rule of this magnitude, the Administrative Procedure Act does require at least a 60-day comment period. So, interestingly, it's interim final with a comment period, allowing the administration to actually implement this and move forward immediately. This, as Jim noted, the MFN rule replaced the actual advance notice of proposed rulemaking that outlined the International Pricing Index model. And the difference with the MFN rule, it does not include that third-party vendor or that cap-like vendor program that would have, in essence, replaced the buy and bill program. The IPI model was a mandatory demonstration, as is the MFN. That IPI model would have only affected half the country. The MFN model is mandatory nationwide. It is envisioned to be a 7-year demonstration. It puts a cap on a certain number of drugs. That there's a top 50 list that is included both at the CMMI website as well as in the Federal Register notice of the rule. And it will be, that rule that top 50 list is determined based on spending for separately payable drugs under the Part B program. That list will likely be dynamic. The first year will start with a top 50. Again, you can find those in those documents that I mentioned. We could actually probably put in the chat links to those if you wanted to see them. The cap or the benchmark price that will cap the payment for those 50 products is based on the lowest price that a drug manufacturer would receive from a basket of countries. So we still have an external reference price, if you will, based on a market basket of countries, some 22 countries that have GDPs similar to the US are included in the mix. And CMS will actually be doing data collection and looking at the lowest price for that top 50 drug list. And those are identified by HCPCS codes. There's a 4-year phase in to this new pricing structure or model. The 4-year kind of phase in is blended on a combination of the current ASP model and the new MFN price. So for the first year, starting January, if this thing is to move forward, the structure of the balance will be 25%. The payment will be based 25% on the MFN price, 75% on the current ASP. And then there's an add-on for those particular drugs of $148.73. That was determined based on a calculation looking historically at what the ASP plus 6 resulted in for those top 50 drugs. So that's a calculation and a formula that would be done and updated on a quarterly basis. Next slide, please. So again, I'll kind of hit the critical pieces here. Participation is, as I mentioned, mandatory nationwide. There are a few exemptions: cancer hospitals, children's hospitals, federally qualified health centers, but physician practices, health systems, hospitals, any entity in large part that bills under the Medicare physician fee schedule and the hospital outpatient prospective payment system would be subject to this rule. The scope of drugs is relatively broad. Chemical drugs, biologics, biosimilars will also be included. There is one biosimilar, Udenica, that is included in the first year, the top 50 drugs. We expect, based on spending, that will continue. That list will evolve, and additional biosimilars could well be added in the years throughout the program, throughout the model. Provider reimbursement. Providers, if that are not able to secure an acquisition cost of these products at or below what that MFN price would be, they can decline to take the financial hit from it. And unfortunately, the net effect with that would be to limit patient access and potentially forcing patients to go to another site of care for that particular drug. And just finally on this slide, then we'll move on. We will, the CMS, the actuary estimates that this model would save between $85 and $87 billion over the 7 years of the model. The concerning thing, and everyone's that's around me tired of probably hearing me say this, but it is shocking that part of that 85 billion, there is acknowledgement that probably about 25% of those savings will come from beneficiaries not being able to access to the medication that was prescribed to them. So that is those are the highlights for the rule. Jim, I'll turn it back over to you to update us on what's happening in the legal front.
Thank you very much, Stacie. So I'm sure it will be a surprise to no one that this rule was not well received, and that very quickly and immediately the manufacturer community and the oncology community, others came together to challenge the rule. At this point in time, there are now 3 lawsuits in federal district court. Your standard way for the non-lawyers out there to challenge a rule like this would be to bring a case in a federal district court before a federal judge to challenge it on the basis of violating some federal law or asserting that it's unconstitutional. And also a federal district court judge has the power and the ability to issue an injunction to block the rule from becoming effective. That could be a temporary injunction to block it for a period of time, or it could be a permanent injunction if the court finds it violates the law. So the first 2 lawsuits were filed on December the 4th, one here in Maryland, U.S. Federal District Court by Pharma, and some other plaintiffs we'll talk about in a minute. Bio made the decision to challenge in California, and they challenged in the California federal court. And then the Community Oncology Alliance, just within the past week, filed a lawsuit, frankly, in the D.C. U.S. Federal District Court. That's the court where most of these challenges to regulations take place. But obviously, the lawyers working with all of these parties strategically decided to go to different courts. I wouldn't be surprised, and I think it's probably true, that there was some coordination there where they thought we're going to try 3 different options here in the event that one court is less favorable than another. And that also, when there's a conflict between the courts and it goes to the circuit, that forces the Supreme Court to address the issue quickly if there is, in fact, a conflict. The legal arguments broadly, we'll talk about them in more detail. The first one, as I mentioned, the Administrative Procedures Act, that is the roadmap for if you're at a federal agency and you want to implement a new regulation. It's very clear in terms of the rules and requirements for what they call notice and comment rulemaking. And I think, as we'll talk about in a minute, there's a good argument they were not properly followed here, and there wasn't a justification for an interim final rule. There are arguments about constitutionality, that the way the administration did this exceeded really the grant of power to the administration. And the third is there's an argument that since, as Stacie said, they're doing this through CMMI, the Center for Medicare and Medicaid Innovation, and that was created, of course, in 2010 under the Affordable Care Act with limited power, really to do demonstration models, that this is much broader than a demonstration model. And it's really a mandatory national program and a complete change in Part B reimbursement, and therefore exceeded the authority that Congress granted CMS and CMMI in the Affordable Care Act. Next slide, please. So let's just take briefly a look at the California case, high level. Biocom California, California Life Sciences Association were the plaintiffs. Again, the arguments were, and these 3 arguments, there's 2 of them here, but 3 of them come up over and over again. The first is that it violated the Administrative Procedures Act because you can only issue this concept of an interim final rule, which is a very weird dynamic where the federal government says, we're going to make it effective today, and then we'll start whatever the rule says we're going to start whenever we want to, and then in the meantime, if we get comments and criticism, we can go back to notice and comment rulemaking. Maybe we will, maybe we won't. But it's supposed to be used in an extreme and unusual situation where it's impractical, unnecessary, contrary to the public interest to do normal notice and comment rulemaking. Secondly, the Affordable Care Act argument, again, is that Congress didn't give CMMI the authority to do anything more then try out some demonstrations. Frankly, a lot of them sort of value-based care related demonstration projects where CMMI had the power to change existing law so the demonstration could be let run. And then the third is a constitutional argument we'll talk about in a minute. In all three of these lawsuits, along with the legal arguments, there were sort of very practical arguments made. The first practical argument in the California case was that this rule will, of course, hurt patient access, and Stacie just articulated that there. And it is somewhat stunning that the administration basically seems to acknowledge that, which again, I don't think any of us who've been doing this for a while have seen before. And also in California, they argued that there were operational issues with regard to capacity and supply, et cetera, that would be impacted, that would be illegal. Next slide, please. What I'd like to do now is all three of the principal arguments here really got a closer look in the Maryland case. The Maryland case was brought by Pharma. So Pharma, of course, being the largest player here, along with Pharma, the National Infusion Center Association, the Global Colon Cancer Association, and the Association of Community Cancer Centers joined as plaintiffs. Again, for the non-lawyers out there, others are allowed to enter into litigation like this, can file a brief. And particularly if there's a lower court decision that goes to the next level up, the circuit, in the case of the Maryland case, it would go to the Fourth Circuit. They could choose to intervene as well. Practical arguments here. I'm sorry, apologize. Legal arguments, again, the same three legal arguments. First here, exceeds the statutory authority of CMS. We and the lawyers, the healthcare lawyers at our firm, have been tracking for several years now a lot of legal thought that has been going into the proposition that CMMI was doing broader and broader things that really exceeded the authority that Congress gave it in 2010, and that at some point it became pretty clear this was going to get litigated in court, and the issuance of this rule created the circumstance to litigate it. Second were the constitutional issues. There were arguments here that this is so broad that basically the administration, the executive branch, is legislating. And of course, legislating under our Constitution is what Congress does, the legislative branch, not the executive branch. And that's the principal constitutional argument, and there are some others. And then there's the argument, of course, that it violates the Administrative Procedures Act by issuing it as an interim final rule. Now, in the Maryland case, they also made some practical arguments. And I say, they wrote it into their legal pleadings. One of them was basically, look, it's not really a fair comparison to use a bucket of pricing from other countries when those countries engage in government price setting. They have single payer systems. They have different value judgments, and they don't design it in a way to hurt patient access, such as this rule does. And then they really, highlighted the fact that 90% of recent new medicines are available in the U.S., but only 49% available overseas. So this is not really a fair comparison. Next slide, please. Briefly, on argument number one. Again, argument number one is this is the Affordable Care Act didn't authorize CMS to do it. So this is excessive. The administration said, well, really, this is just a pilot or a demonstration. What's the big deal? That's what CMMI is designed for. Like, why can't we just do this pilot and change the existing reimbursement model? The Pharma position is no, you cannot. The ACA was very clear in its limitations. And not only that, there are a series of requirements that you have to do, such as identifying your population, articulating a clear goal, starting with a narrow pilot, doing a study, et cetera, that you normally do in a CMMI pilot program. That was not done here. And so that's the Pharma position. Who's the winner here? We think Pharma is likely to win this argument. And when I say Pharma is likely to win this argument, the same argument is being made in the Maryland court by Pharma, in the California court by Bio, and in DC by the Oncology Alliance. So we think this is a winning argument. Now, to be clear, and I want to be somewhat careful about this. There are Congress, when they authorized CMMI to do demonstration models, they did build in some restrictions on the ability for the models to be challenged. It was really designed to prevent somebody from bringing one lawsuit and shutting the whole operation down. But we think that's not going to be dispositive here, and we think this is going to be a winning argument. Next slide, please. Argument number two is the constitutionality argument. Very briefly again, the argument here is that the administration is not just implementing a new drug pricing model, but they're repudiating an entire market-based approach that Congress, has implemented over a number of years. And basically, again, in the end, it's that the White House and the administration and HHS doesn't have the ability to legislate. Only Congress can legislate. In the end, is this a winner? We think this is a toss-up. Courts do not like to make decisions on constitutional grounds if they don't have to. There's another basis here to make a decision. And we think in the end that none of the three courts is going to declare it unconstitutional. Again, that could be wrong, but that's how we handicap it right now. Next slide, please. And the third one is, of course, the Administrative Procedures Act challenge, which we've talked about a good bit. The real point I want to make here is the administration and HHS and the Trump administration is in a weak position arguing that there is some sort of an urgency, urgent situation here, because they have been pressing for drug pricing reform for 4 years. So it's hard to persuade the court that was something that happened in November that made it essential to do this in November and December and get going by early January. So it's a weak argument in the end. We think this is also a winning argument. We do believe that one of the courts, the federal court in Maryland or the federal court in California, most likely, but it could be in the court in DC, are going to issue an injunction at some point. We are not saying that we shouldn't discuss this and plan for it. And there's always a possibility it doesn't happen, which is why there are lawsuits in 3 different federal courts. I don't think the industry is taking its chances here, but that's how we see it right now. Next slide, please. So with that, Stacie, let me go back to you on the rebate rule, and then we can talk a little more about that, please.
Yeah, and I will just make one mention, the legal challenges, I think it's quite a fluid situation, and probably additional suits will be filed. We did just see, and I think we all get a lot of news from Twitter these days, unfortunately, on the policy perspective, but I did see that the pharma suit, the Maryland District Court has announced a hearing for this coming Friday morning at 10 a.m. So we should, by the end of the day or very early next week, at least have some signals of what the administration, how this first challenge that will be heard, will go. So we will continue to update the, Cardinal team, and I'm sure everybody will be certainly watching, and it will be well reported on, I'm quite sure. So I also see we have a lot of questions about the rebate rule, and we certainly will get to those. I think the MFN rule. I think the rebate rule conversation is a little bit more concise. The rebate rule that was just finalized and issued also on the same date, November 20th, is quite similar, if not identical, to the original proposed rebate rule that was released, last year in January of 2019. So I don't think there's any surprises, in the rule here. Obviously, the goal is to evolve the current rebate structure into a discount system where the benefit of that negotiated rebate or discount, if you will, between manufacturers and the plans and PBMs would actually go to the patient at the point of sale. So the rebate rule, you can move to the next slide and we can just go ahead and kind of hit the highlights here. What it does, it amends the anti-kickback statute, safe harbor, that historically for a number of years actually covered or provided protection for those rebates that were paid, again, negotiated and paid between manufacturers and the health plans. This rule, it's final. There is no comment period on this one. It is scheduled to take effect January 1 of 2022. The timeline on this is, much more, I would say, reasonable if you want to say that, than the original proposed rule that was going to be a very quick implementation timeline. And I think, along with concerns that the rule would actually increase costs to the federal government, to beneficiaries in the form of premium increases, et cetera, I think that from an operational perspective, there was a lot of concern that it couldn't be implemented within just a few months. So one note on the implementation cycle of this, that's just one sort of, bidding cycle, if you will, As you all know, the bidding process is a springtime, early summer kind of event on an annual basis. And by really middle of the summer, middle of June, actually, the bids are finalized. So it is still a relatively quick turnaround time. Obviously, the net effect of this change in the anti-kickback statute, again, would be to allow a safe harbor for those discounts that would then be paid to passed on to the beneficiaries at the pharmacy counter or the point of sale, as opposed to, to those rebates. So the rebate kind of structure would no longer be protected. And what this is really doing is sort of changing that dynamic. PBMs in this model would really no longer be based on a percentage of the list price. They're going to be paid based on a fee structure that's based on fair market value. So we also expect, we have not seen any, that's not to say that they are not in the works. We fully expect the PBM industry and maybe plans would and will challenge this rule in some parts on the same, some of the same arguments, really kind of violation, if you will, of the Administrative Procedure Act. And interestingly, with this rule was published and withdrawn. There was actually, for those of you who kind of look at the documents and look at the agendas that are posted at the OMB website, it was listed as withdrawn, last summer. It was not, however, published. The withdrawal was not published in the Federal Register. So that has sort of set up this interesting dynamic here as well. I think presenting challenge, bases for challenge in the court system. So Jim, if you don't think I missed anything on the rebate rule highlights, perhaps we can just move forward.
Perfect. Thank you, Stacie. Next slide, please. Okay. Thank you very much. So briefly, I'd like to take a quick look at sort of what to expect in the Biden administration and the 117th Congress. Let me just preface with just a couple of quick thoughts. Again, it's our assessment that some of these arguments on the merits should be winners, but we obviously don't guarantee. We can't guarantee that. But regardless, a court is going to have to make a decision before January 1st whether or not to grant even a temporary injunction. One option here is to grant an injunction that basically stays the rule from being implemented, so it doesn't go into effect for a month or so until there's a new administration, and their team at HHS can decide what they want to do and if they still support this rule or not. Of course, if to the extent that there's a hearing in the next week or so, obviously that tells you that the courts are trying to move fairly quickly on this. And I think there will be pressure in all three. There will be a decision from one of the three courts before the end of the year about whether it will whether the model will be implemented in full at that point as of January 1st or not. Meanwhile, next slide, please. On January 20th, the Biden administration will come in. It will have as basically one of its four big healthcare priorities, drug pricing reform. So this is one of those rare issues where changing administrations does not change the focus on the issue. Now, obviously, the Biden administration is going to have to spend a lot of time on COVID-19. It's going to be trying to hold together the Affordable Care Act, and it's worried about a Supreme Court opinion on that act that is going to come next spring. Which could be pretty damaging, and it's going to want to reverse some of the Trump administration policies. But drug pricing reform will be on the agenda. However, moving drug pricing legislation through Congress, given everything else on the Biden agenda, I would not expect to be something that happens in the first month or so. I don't expect it in the first 100 days, which would take you through May, but because the Trump administration issued this rule, that may raise the profile of the issue, will raise the profile of the issue in the administration. Next slide, please. Again, and this is just an outline of some of the different priorities next year. Affordable Care Act is a big priority. Actually focusing on CMMI and expanding their role to some degree is a priority. But we do not think that that means the Biden administration will agree with the way that the Trump administration did this. Drug importation, even the Biden administration wants to explore further limited drug importation. I'm sure many of you know that the Trump administration put out a rule and basically opened the door to applications over the last couple of weeks, but there's been none approved yet. And certainly the state of Florida was the first that talked about submitting one of those applications, but that hasn't moved. And then, of course, insurance coverage will be a big issue next year. But no question, as we all know, that COVID-19 will be the top priority. The question will be, what will it mean that the Trump administration did this in terms of the Biden administration? And they're going to have to act on this rule at some point, and they will probably be dragged into court to explain it to the judges in court as well. Next slide, please. What to expect on drug pricing issues under the Biden administration, aside from this, Biden and Sanders had a unity task force, as they call it, which made certain drug price recommendations. One of them is certainly Medicare price negotiation, this concept of the government leveraging its full bargaining power. One of them was some version of an international reference pricing model, whether it be an MFN or otherwise. One was an inflationary pricing penalties, or caps. That really held up the Grassley bill in the Senate, but the Biden administration might come back with that again. And one was a focus on limiting prescription drug advertising. The Center for American Progress, one of the prominent think tanks, the leader of that organization, Neera Tanden, has been nominated to be the head of the Office of Management and Budget. And you may recall, we discussed earlier in our discussion, during the Trump administration, the fight between HHS, the Department of Health and Human Services, and the Office of Management and Budget slowed down the movement of the drug pricing rule, and query whether that will happen again in the next administration. And another thing they want to do is take a look at the 2016 Obama era Part B demonstration to reduce ASPE plus add-ons for Part B drugs from 6% to 2.5%, plus a flat fee. So regardless of whether this Trump proposal is ended or not, the Biden administration is going to be coming back again on the issue next year. Next slide, please. Briefly, the players, the new Secretary of HHS will be Javier Becerra, former Congressman, very practical, very logical. I think he and his team, unlike Secretary Azar, he doesn't come from the industry. So he has some strong views, but most of them are on Medicare for all and other issues, and not necessarily on this issue. So it'll be interesting to see how this plays out. Rochelle Walensky, I think we know at CDC. We obviously know Dr. Fauci, Vivek Murthy, a Surgeon General, although I don't think any of these folks are going to jump into the drug pricing issue up front, with the exception of Secretary-designate Becerra. Next slide, please. Yeah, and I realize this is difficult to see. I will just leave this in the presentation, and I know many of you may have it afterwards, with the following point. The key leaders are changing over for some of the key healthcare committees next year. If you live in a state where your senator is a chairman or chairwoman or ranking member on one of these committees, you may want to express your views on this issue, on MFN or otherwise, and certainly think about that. An example would be, Senator Wyden has been there for some time on the Finance Committee, and obviously some of this, whether they're chair or ranking member, will depend on what happens on January 5th in the Georgia Senate race. Next slide, please. So, Rebecca, I think that brings us to the end of our presentation portion, and now we're happy to work with you and Stacie and the team and answer any questions, please.
Wonderful. Thanks so much, Jim and Stacie, for that overview. We have about 15 minutes for questions, and I know that we had quite a few come in the chat and some pre-submitted as well. So we won't get to all of them, but we'll do our best and also hope to answer some afterwards as well. So looking to one, Stacie, that came in the chat about biosimilars. Biosimilars are not on the list, but the rule states in multiple places that they're included. However, what can we tell about what the reimbursement rate would be since they're not on the list? Any thoughts about this? Welcome your feeling based on what we know and also what we don't at this point.
Yes, and I can confirm this and share out with you, Rebecca and Dan, and you can pass that along to the participants. I was under the impression that there is one biosimilar in the list, and that's Udenyca. So we can see from that list, there is a table in those same locations that I referenced earlier at the CMMI site as well as in the Federal Register rule itself, the publication. There's table 2, if you want to look there for the actual list of 50 products. And then there's a table 6 in that same addendum that includes what the anticipated, it's really an illustrative example of what the first year payments would be. And they use a sample country, and they use the blended rate. So in that table, it lists what the current ASP is, what the expected MFN blended payment rate would be in the first year, and then what the difference is. And ultimately, I think it nets out at about 33% on average. The MFN, the first year payment would be about 33% of the ASP that that they're blending from. Ultimately, in year 4, the price difference would be closer to about 65% in terms of comparing what the ASP rate is compared to the MFN rate. And all this, again, is just illustrative. If you want to look for, keep an eye out. One thing, I have been babysitting the CMMI website. I have not seen a list of official prices for the first year published yet. So I think that's a big signal of where we are in terms of CMMI getting ready and standing this up by January 1. Unless I've missed it, I have really not seen any additional information that would give us guidance on how to move forward as of, with the January 1 date.
Great, thanks, Stacie. Another question that was submitted in advance and also in the chat is around sequestration. Can you talk about when sequestration might start up again, and will it be the same percentage? What do we know about that at this point?
So the CARES Act passed earlier this year, obviously, COVID relief package, very significant COVID relief package, included a suspension of the sequestration. So it was suspended from May through the end of this year. Absent any additional relief, either provided through an additional, COVID bill, or potentially Jim might know how to handicap whether we think there would be any way there would be any other opportunity for a sequestration, a further kind of suspension to be added on to maybe the budget kind of package that we look to see passed by the end of this week. But failing that, I think we will see sequestration start again January 1 and at the same rate. And unfortunately, the impact of pushing out or suspending sequestration pushes that out one more year. That will take us all the way to 2030.
Great, thanks, Stacie. Jim, do you have additional thoughts on that, and what the atmosphere is on the Hill around sequestration?
So I agree with Stacie. I think they're gonna make a decision now in their negotiations. I think, as everyone knows, the Congress has to come up by Friday, 2 days from now, with legislation that funds the government after Friday, because they extended with a continuing resolution to funding of the government to Friday. I think it's part of the discussion now. Obviously, as Stacie said, the suspension lasts through the end of the year. It hasn't been a hot issue publicly, but I think they may decide to extend it a little bit. I don't think so, because they're probably factoring it into their calculus. But the whole discussion is going to start all over again, because in the congressional calendar year, the first few months are the time of the year when the president issues his or her budget, and then the Capitol Hill passes a budget reconciliation bill. So it'll become part of the discussion again next spring.
Thanks, Jim. We have a couple questions in the chat about the add-on. If it's per dose, Stacie, can you speak to that, or is it for the entire infusion?
It's per dose. So if there are multiple drugs, multiple infusions administered in an encounter, it would be per dose.
Okay, thank you. One of the questions we got in advance was on Medicare Advantage plans. Stacie, coming back to you, can you talk about if the MFN applies to those plans?
Yeah, the MFN does not apply to Medicare Advantage plans. One kind of qualifier here, I would say, is that, Part B payment expenditures are used to establish the benchmarks that ultimately go into what those bids look like and the payment structure for the following, plan year. So while it doesn't technically or officially apply to Medicare Advantage plans, it may have some effect in terms of what those those rates are going forward.
Great, thank you. Next question is around just the process of submitting comments. And this is something Cardinal had the same conversation and kind of grappled with. We obviously know the implementation date is before comments are actually due on January 26th. And what also makes that interesting is they'll be submitted and read by the Biden administration, not the Trump administration. Can you just talk about that a little bit, Stacie, with that dynamic and how folks might want to approach the commenting period?
Yeah, no, I think it's critical to comment. As Jim was mentioning, we really don't know. I think we have, those of us who've been kind of watching this and are concerned about it think that we hopefully will see some action before the actual implementation of this. But I do think those comments are critically important, whether it moves forward or becomes, the potential, for morphing into yet another type of demonstration. All those comments, it's my understanding, have to be read and have to be considered, unless the rule is completely, pulled and never to be resurrected. I do think it's worth the exercise of submitting those comments. And really, there are a few areas that CMS or the Innovation Center is looking specifically for comment. They actually want input on what products should be included in the list. They want specifically to know whether cell and gene therapies should be included on the list. So I think it's critical to take the opportunity and comment.
And Jim, do you have any sense? I know you talked through the different cases that have been filed, and Stacie mentioned the upcoming hearing, but do you have any sense of when the courts might make a decision, given we're marching right towards the holidays and January 1st is right around the corner?
I think I think that the parties, the plaintiffs, have already asked the courts, they have, to accelerate the case. I think that if for some reason, one of the judges in one of the three cases is moving more slowly, I think they have the option to go back to the court to ask for a temporary injunction. Where, in their own case, it's another pleading, another request to the court, and the court has to respond to that quickly. So I would expect today is obviously the 16th. Everyone knows, by next Wednesday, I would expect that if the parties are not seeing movement they are now in Maryland, and I think they'll move in all three courts. But if they don't move more quickly, I think there'll be another pleading to seek a temporary injunction for a certain period of time until the court decides on a permanent injunction or not.
Thank you. And I know we've seen quite a bit from COA and the ASP Coalition, a lot of other sort of stakeholder and advocacy groups weighing in. Stacie, do you have any thoughts on how their messages are being heard about the impact of this, both of the current administration, but also with the Biden team as well?
Yeah, I do think some of the circumstances around the rulemaking process here is a bit extraordinary. I do think some of those arguments, are probably being very much considered. There is a lot of effort to put in these, to stand up these types of models. There really should have been a change. Really, this is a regulatory sort of structural change to the Medicare Part B program. And obviously it's starting with 50 drugs, but we see that the anticipation is that list will continue to grow. Those 50 drugs, unless they're no longer marketed, will continue on that list, and that list will grow every year. So I think a signature, substantial change, substantive change that really circumvents, the kind of the legislative process, if you will, the congressional process, are really going to resonate as they have in the past. I mean, we saw the Part B demo. Obviously, that was under the Obama administration. There was a huge push, and I think the concerns around that, COA, I recall, called it an experiment. There was just this huge concern that, there were going to be 50% of the country whose outcomes would be quite different. Patient outcomes would be quite different because of the result of kind of the structural change in the Medicare payment process. So I would have to think that these arguments and the concerns will be well considered by the incoming administration.
Yeah.
Thank you. I'll go ahead, Jim.
Sorry, very briefly, Rebecca. I think we all know Vice President Biden obviously lost his son, Beau, to cancer. He started a cancer foundation between leaving the Obama administration and today. I think this is very personal. There's the argument that this will reduce patient access to oncology drugs is powerful. And if ever there was a time where folks may want to engage through comments to the rule or directly with members, I think now's the time.
No, thanks, Jim, for that. And I agree. I've seen a number of comments. I'm in the chat talking about the potential impact on folks' businesses. And I think that those stories are really important to share directly with the Hill. And so
Yep.
now is exactly the right time to be making those points as the transition team is working and starting to get up to speed on key issues. Dan, I know you're on as well. Wanted to raise a couple questions for you. Groups are continuing to hold off on ordering through January as they're concerned that they'll be underwater on the products that have been outlined. Do we believe manufacturers will be taking a bigger hit on these proposed changes or practices? And do we anticipate any adjustments from manufacturers to keep practices whole?
Yeah, Rebecca, thank you. Great question. I think, we certainly anticipate that the immediate impact, at least, is going to be from a practice perspective, but we are working intently with our manufacturers to identify, as we have in the past, to identify alternative solutions, working with payers and certainly with policymakers. I think this call serves as an example of our interest in ensuring that that community oncologists are kept independent, have the opportunity to treat patients successfully in the space as well.
And one more, if the MFN interim final rule isn't overturned through the courts by January 1st, has Cardinal Health evaluated ways that we could possibly support customers through this transition period?
Yeah, it's a great question. I think, very similar to what we have seen earlier this year, we've continued to evaluate opportunities and ways that we can continue to support practices very similarly in the, during our initial phase of COVID. I think, it's considering it's a reimbursement issue, we're really going to have to work with our manufacturer partners to identify, a variety of different strategies that they can implement and that we can do to support them along the way.
Great, thank you. And with that, a big thank you to our panelists, to Jim Flood and Stacie Heller. I really appreciate you spending this time with us. And Dan, I'm going to come back to you to wrap us up and for some final thoughts.
Absolutely, Rebecca. Thank you. And once again, I just want to thank our panel, Stacie, Jim. Very much appreciated your expertise. And I think once again, as I mentioned kind of in the opening here, is that our commitment to the space of all the therapeutic areas that we serve. We certainly believe that Cardinal is essential to care in those areas, and we are committed to our partnership with our physician office practices across all therapeutic areas. We hope that this brought some additional insight, and please rest assured that Cardinal Health as an organization has the partnership with our practices to make sure that we're continuing to bring access to patients. So on behalf of Cardinal Health and all of our group purchasing organizations, I'd like to thank everyone for joining and we'll continue to send out communications daily. Thank you very much.
Thank you.
Thank you.
Thank you.